Welcome to Practice Pearls, Overcoming Therapeutic Inertia. Today, we're going to discuss some tips on language as an inertia buster, what works to build trust and promote rapport. I'm Dr. Neil Skolnik, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. And joining me today is Shannon Knapp, who is a registered nurse, a certified diabetes care and education specialist, and manager of diabetes care and education for the Cleveland Clinic Health System. In that role, she's responsible for coordinating, supporting, and leading the efforts of diabetes care and education across the Cleveland Clinic. Not too shabby. Welcome, Shannon.
Thank you, Neil. Nice to be here.
Just to level set before we talk, it's important for all of our watchers to remember that therapeutic inertia is defined as the failure to advance or to de-intensify treatment regimens when a patient's therapeutic goals are not met. Clearly, we'd agree that the language that we use influences our patients' trust in us and subsequently their desire to carry out the recommendations that we give to them. That's intuitively obvious, but not everything that is intuitively obvious is actually true. Shannon, is there any evidence that language choice can impact patient outcomes?
Yeah, this is something that we've really talked about over many years in diabetes care, is the importance of the use of positive language with our patients. And but unfortunately, it was also something that we didn't have a lot of research behind until recently. So a few years ago, Jane Dickinson, she's been a big proponent of the use of positive and non-judgmental language in diabetes care. So she did a study, so we do have some data from that. And her study, it was a qualitative study. She looked at patients who what kind of messages are they getting? So what kind of messages do they hear? Now, it was not just looking at messages that they're hearing in healthcare, it was also looking at messages that they're hearing in the public and through media. But she was specifically asking about negative messages and what do they consider, what do they perceive as negative messages? So it was interesting to hear that she kind of classified them, and she saw that they were hearing judgmental messages, labeling messages, and there were also some messages that were promoting fear and anxiety among the patients. Yeah,
that's really helpful. It's helpful to know that there's an evidence base that supports what we think, because when we use the wrong language at home with a partner or a kid, we get that feedback very quickly. We don't get that feedback from our patients, and that feedback through research is so helpful. What would you say are some examples of supportive language in diabetes care?
I think one of the big ones for me is use of person-centered language. So things like people with diabetes instead of diabetic. Diabetic is such a label. And to be honest with you, I have had type 1 diabetes myself for over 35 years. And I did not fully, I practiced the appropriate language, but I cannot say that I fully bought into it, because in my head, I often would think, well, what's the big deal? I am a diabetic. But then I started to think of it in different terms. I thought of the little boy who lives next door to me who has autism. And when I thought of him, I thought, if I describe him to people as the autistic boy who lives next door, then the definition of him is autism. But if I describe him to people as the boy who lives next door who has autism, then he's a boy who lives next door. So I really kind of shifted my focus and reframed it, and I was able to apply that to diabetes and really able to practice what I preach.
That's a profound observation, and I think the language we use to describe ourselves and others influences the way that we think about ourselves and others. What do you do when patients themselves use some of that judgmental language that we're trying to avoid?
Yeah, and that will absolutely happen. There are some patients who are, they hear about this movement towards positive language, especially through social media. But there are also a lot of patients who do not hear this, and so they don't know about it, and they don't really think about it necessarily. So when patients come in to talk to me, I model it. So I will speak in those positive terms. I think there's one in particular that I will call them out on, though. So if they refer to their blood sugars as good or bad, so good applies also, because the opposite of good is bad. But if they say to me, well, I'm glad to be here today, but oh, my blood sugars are bad, I will tell them, no, your blood sugars are not bad. They're either in your target or they're out of your target. So if they're out of your target, now our next question is, what can we work on together to see if we can get them back into your target? Because good and bad is very judgmental from a patient's perspective, and whether they realize it or not.
That's a great point. So if you had a recommendation for primary care physicians, PAs, nurse practitioners, and pharmacists about language choice to help overcome therapeutic inertia, what would that recommendation be?
I would say state the facts. I mean, that's really what it comes down to in here. Besides using person-centered language, I think that what we really need to try and do is just state the facts. So if we think about terms like compliance, because that's another one that has come up a lot, we have kind of shifted from non-compliance to non-adherence. But in my opinion, that's just really using a different word to say the same thing. So when I think about it in terms of if a provider puts non-compliant in a patient chart, when that patient comes to see me as a diabetes educator and I look at that word in their chart, they're walking in and I already have a preconceived notion about them, regardless of what I practice and what I preach. So what I would rather see is patient is currently checking blood sugar once a week because they cannot afford test strips. Because I can do something with that and I can help them. That's really speaking to the barriers that they may have, and it's stating the facts rather than making a judgment of non-compliance.
These are incredibly important parts of our approach to patients with diabetes. And if I can summarize what I've heard, it's about being person-centered and it's about being non-judgmental that then allows us as clinicians to meet people where they are at and to help them move to where they need to be. I thought this was fantastic, Shannon. Thanks so much for joining us. For more on overcoming therapeutic inertia, just go to therapeutikinertia.diabetes.org. For the American Diabetes Association, I'm Dr. Neil Skolnik. Thanks for joining us.